Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast.
Alrighty, Carol asks, what is the difference between a periapical lucency and an abscess? And are there differences in treatment? Excellent question. I'm glad you asked this because a lot of folks will see that bone loss and they will call it a periapical abscess. An abscess is when we have active draining pus, whether we have an open wound underneath the eye from that root, breaking through and coming to the surface, or inside if we see active draining pus from that tooth, that's an active abscess. When we just see bone loss with the absence of all of that, that's a periapical lucency. It will most likely progress to that point at some point because there's infection there, and very typical to see that suborbital swelling and eventual break through the skin type of abscess behavior from an infected fourth premolar. The treatment pretty much is the same. It's going to be extraction. It's going to be debriding infected bone, infected tissue around that tooth, and then closure, and then antibiotics. In antibiotics, we don't typically dispense unless we have active pus, active infection post-op. We will do an ampicillin injection intraoperatively, but in many cases we don't dispense antibiotics post-op unless we have that active infection, especially that wound in the face. We're going to want to make sure that we're covering that. The mouth has a tremendous blood supply, and there's a significant exchange, blood exchange. So all of that is kind of carrying away any micro infection that might be there once we've extracted the tooth, debrided infected bone, debrided infected tissue, and closed with as much healthy tissue as possible. The immune system is really going to take care of anything that's left. But those are how extractions need to go, where even if it's a very loose tooth, it's not about the extraction. It's about debridement and closure, just like any other infected wound. An infected laceration is going to be debridement of all that nasty tissue and then closing with healthy margins. And that's what a skilled oral surgeon does with any of those advanced, especially advanced periodontal cases or teeth that have been fractured and it's now 2 or 3 or 4 years down the road and we've got infection surrounding that tooth. So all of that is debrided and removed as part of that patient's procedure. All right, Sonia asks, is there a sensor that you know of that is smaller than the one used? It is sometimes impossible to reach the back molars on small dogs. Yeah, there really is only the number 2, and that's what I use on everybody from a 3-pound Maltese to a 180-pound Irish Wolfhound. And it's all about, again, doing that troubleshooting and using your tube head in such a way that if you can't get that sensor all the way back, you can adjust your tube head to throw the shadow onto where your sensor is. And so in a lot of cases with those last molars, I'm going to oblique or have my tube head kind of facing back to front in order to throw that shadow forward. And so it really helps with having that tube head and knowing where your shadow is thrown based on where your sun is in relation to your sensor. So you can throw the shadow backwards onto your sensor or forward onto your sensor just by changing that side to side angle. Another question from Sonia. For chew toys, what is your best recommendation that is safe for dogs? And yeah, there's a number of toys out there, and a number of plaque prevention, and I say that with a grain of salt, because there's a lot of products out there, and we see a lot of patients that unfortunately are chewing on things that, number one, have absolutely no benefit as far as plaque prevention, even though they're marketed that way, and they can actually damage teeth. And the top three typically are antlers, nylobones, and bully sticks. We see a lot of fractured fourth premolars from chewing on those particular items. And so what I recommend to my clients, two things. Number one, anything in the Kong line, because Kong has give to it, where they can bite down on it, but there's some absorption of that force where we're not going to have fractured teeth. And anything that is on the VOHC list as far as dental chews and any other plaque preventative type of materials, so that they have a direction to go out and look for that symbol or seal on whatever product they want to use. So some dogs have food allergies, some have other issues that they need very specific types of home care. And so if what we have that we dispense doesn't work for that patient, I have those lists printed up and are available for those guys to have, and be able to still do effective plaque prevention as well as safe plaque prevention. Alrighty, Brittany asks, do you have anyone monitoring vitals while taking x-rays? In the video, you're taking cat x-rays. I didn't see any EKG leads or anyone else there with the patient. And so when I induce a patient, they are sternal at that point. I'm going to put pulse ox on them right away. I have the breathe safe monitor, so I know that they're respirating. Typically, it's only maybe 5 minutes, then I'm turning them in dorsal recumbency, and then all of those leads are going to go on. But I am monitoring that patient as I'm taking x-rays. And I'm at a point where I'm comfortable enough where I'm not overthinking x-rays. I can do those in my sleep. And the majority of my attention is on that patient. I'm going to listen for that breathe safe to beep, that I know he's breathing. With the pulse ox, I can see the heart rate. I'm looking at the mucous membranes consistently because I'm in the mouth. And so all of those parameters, so I'm monitoring that patient from the outset. And then once they're dorsal, it's much easier to get those leads on without twisting and tangling them up. And then we move on from there. But it's just a few minutes. Now, in general practice, when you're taking x-rays a little bit longer, you're concentrating on that. Yeah, you might have someone who's helping you during that time, or put the leads on right away, just so you have your comfort level is a little bit better where that patient is monitored, because a lot of folks, they're just concentrating so hard on getting x-rays and getting good views that sometimes that takes all of your attention. So sometimes it's helpful to have help. All right, good question. Michelle writes, when do you attach your monitoring device? I see you already have the Safe Breathe attachment. And again, typically once they're in dorsal recumbency, we hook up the fluids and all of the leads. We will have to adjust them again, depending on what surgical procedure is going to need to be done. But in most cases, it's once they're on their back, and then we can hook those leads up very, very easily. Our cadaver specimens, we have two resources, Skulls Unlimited and Carolina Biological Supply. Those two resources, we can typically get cadaver heads, and we're ordering multiple. You guys are going to order one of each and ask for medium dog. as opposed to large or small. Medium, usually you'll get medium to large. If you ask for large breed, you're going to get a giant. So ask for medium and then a cat. And so we have really good success in getting our cadaver heads from those two resources. Do you always perform your intubation unassisted? I do. I'm only 5 foot. I'm very short. And this comes from years and years in ER med where, it's just you and the doc and a lot of things you do by yourself. And I just taught myself how to do that. And it's just so much easier for me to position the light, position the head where I can very clearly see into that trachea. Mostly everybody I work with is taller than me, and so I find myself standing on tiptoes a lot, trying to see down into that trachea. And so it just helps me to intubate very quickly, just grabbing that and holding it in such a way where I can access that trachea very easily.
I hope you enjoyed this episode. There's a lot of actionable items in there that you can take and use in your practice immediately. So put those to work and enjoy the benefits for the practice lifetime in your dentistry service. And if you would, please go to iTunes, leave a rating and review, take a picture of that with your cell phone, and then post it on the Vet Dental Show Facebook page. Just go to Facebook, search Vet Dental Show in the search in the upper left, and the show will come up. And once you post that, we'll send you a free instrument use essentials course. So if you want that free course, again, all you have to do is go to iTunes, leave a rating and review, take a picture of the rating and review with your phone, and then post it on our Facebook page, The Vet Dental Show. So until next week, have a great week. Take care, guys.